any advice for community oncologists who may be seeing these patients, either for newly diagnosed and then the relapse setting, that we could advise them with, obviously, because rare disease and there are a lot of therapies that we have, and choosing and duration we talked about, there's enough complexity. But any advice from our panelists, what you would like to kind of share with them?
I think this is a great example of a very uncommon disease where I think it's almost always good to get advice from someone who has more experience. Even if obviously most of the patients will end up being treated by their referring physician in the community, which is appropriate, but there's enough kind of little clinical pearls. You often get calls, someone was treated, it's 2 months later, their counts still haven't fully recovered. Should I treat them again? And, things like that only come with experience. So I would really strongly advocate just, a second opinion. And that really establishes a good relationship so that physician can then contact you after they've treated the patient if problems come up.
I agree, and I think in my practice, this disease is so uncommon that many of the private oncologists do tend to call and ask, and I agree that would probably provides the patients with the best outcome.
I must say this disease is very much driven by the patient rather than the physician.
Yes.
Most of my second opinions don't come, unfortunately, from physicians now. They come from patients. And I only half jokingly said in the beginning that these patients will become world experts. They will. They've read every publication of all the people at the top. They know this disease because they have decades to prepare. But if I had to give advice, it probably would be don't overtreat these patients. Don't treat them just for flow cytometry at relapse. Don't treat them just for minimal residual disease. And most importantly, get the pathology straight in the beginning. It's a tragedy for these patients to be lumped into some other lymphoproliferative disorder for a long period of time when there's a plethora of effective drugs in the armamentarium that the patients can benefit from. Getting the pathology straight in the beginning is probably the best thing. It's not that uncommon for people to come to see me for myelodysplasia and end up having hairy cell leukemia, aplastic anemia. Just get the pathology straight in the beginning, and it's a relatively, compared to what other patients with hematologic malignancies have, private practitioners can do this, but if there's someone who can have some rapport with them, it will be advantageous, but don't overtreat these patients.
Just to add, Ben, being able to at least be tied if it's a patient who it becomes relapsed, refractory, or is not responding as expected, having that tie also for clinical trials is really important so that they can get those exceptions, can get that next level of care.
Yeah, I think that's actually the important point that you raised about getting the diagnosis first time, because the pathology, because I did have a patient with aplastic anemia, presumed diagnosis set for transplant, who ended up getting a second opinion and actually with hairy cell leukemia. And it's such a drastic, obviously, course of a treatment and the prognosis for that particular, this is the mid-40s young woman. So I do agree that because of the rarity of the disease, that you want to be confident of the diagnosis there too. So I agree that's a very important the point that you generated there. And then I think it's very much patient driven. I think with the Hairy Cell Leukemia Foundation and others, there's the plethora of resources for rare disease and good advocacy group, and that also enables this type of clinical trials to happen for this rare disease. So I think it's really fantastic to see, and there's a lot to learn from. And just finish off, there's so many ongoing and emerging research that's also happening in this area, just figuring out the BRAF inhibitor moving to the front line is 1, 2, and then moxetumomab perhaps there's a role in the frontline setting, and all the other newer agents we discussed, and then the MEK inhibitor and combinations. I think this may, as good as the cladribine and pentostatin is for the first line therapy, there's a room for improvement. So I think that these will also coming in the future to whether we can avoid immunosuppressive therapy, especially with what we are learning with the COVID-19 kind of the situations and the consequences of such. Thank you to all of you for this rich and informative discussion that you participate. We have learned a lot about hairy cell leukemia from the basic biology, clinical presentations, and the first and the second line and third line therapies. So I think we have learned a lot from there. Also other additional resources that patients and then oncologists can also look to. And thank you again to our viewing audience. We hope you found this Oncolite Peer Exchange discussion to be useful and informative. Thank you.